Oh, only there. Okay, good. Right, I'm going to talk loud. Try to talk as loud as I can. If my voice goes out, I'll do sign language. No, we'll be okay. But I'm Dr. J. Soileau. I'm an adolescent medicine specialist, family medicine specialist, and addiction medicine specialist here with the LSU Memorial Clinic, and we've been open for about 20 years, but I had my own practice before that for about 11 or so years, and in Lake Charles. And we're going to talk about ADHD across the lifespan, which is, we used to talk about it just ADHD in children, and we'll talk about that a little bit. But I want to mention a few organizations first that could be helpful, and let you. I think if you have the handouts, it's not in the handouts. I wish it was, and we could maybe put it on the website. I'm not sure. Yeah, so we could put this on the website if you miss it. The CHAD organization is a national organization that's been around for a long time. Children and adults with ADHD, and what we now have an online one support group. Local support group headed by Brenda Lear, and her contact email is here. We had a CHAD organization years ago. It's all volunteer run, so it ended up volunteers got burned out. And so, stopped for a while, but we've just got this going again. And there will be support group meetings, and there can be educational parent resources. Online, if you look at chad.org, and I think that one got left off, but it's basically chadd.org is the national website. And it has a lot of resources, some online blogs and different things like that that can be helpful. The other main national organization is Attention Deficit Disorders Association, ADDA, which its national website is listed here. It's very simple, add.org. And it's, again, online community and resources and educational materials, things like that, helpful ways to find the resources you need. And locally, also for dealing with the school system, is Families Helping Families is probably the best parent organization that can help with navigating the school system if you're having trouble with anybody in the family. And I've got websites and everything on that. And they have a website that you can get their phone numbers and things like that from. So let me figure out who we have here. How many of you are educators? How many of you are counselors? Parents with someone with ADHD, or a spouse or anything else, someone in the family? How many of you are just interested because it sounded interesting to you? Okay, so we got a few of those too. All right. Grandparents, right. I forgot to mention grandparents because I know a lot of grandparents are raising their grandchildren or helping to raise their grandchildren or helping out with their grandchildren in some way or another, and that can be difficult, and it can be helpful to have more information. So first of all, disclosures, I will be talking about some things that are not on the label for the medications. That's because in pediatrics, a lot of things don't get tested in the same way by the FDA, but they're tested through the literature, through research that's very good research, but it's just not through the FDA. And then learning objectives are just to have a grasp of the latest advancements in ADHD, also to be more knowledgeable about medication therapies and be more knowledgeable about other therapies other than just medication. And we'll talk more about all those. Now, this humor is kind of helpful, but did you have ADD when you were a kid, Fraz? And he said, no, I had ADHLAS. Attention Deficit Hyper, hey look, a squirrel. And he said, the little kid says, that's what I got too. And so it's helpful sometimes to know that there are other people who are going through the same things that you are, and you identify with those people, and it helps out too. So what are the definitions of ADHD? Originally it was like minimal brain dysfunction when I first started in medicine. That was kind of a not so nice of a term because it implies you have brain damage, and that's kind of what they thought it originally. but it's considered a neurobiologic condition that causes significant impairment in cognitive areas, such as focus, working memory, perseverance in tasks, and may also have severe or significant overactivity and impulsiveness at times, but not necessarily all the time. Another definition is ADHD is a chronic condition marked by persistent inattention, sometimes hyperactivity and impulsiveness. How often do we have kids that are very hyperactive? What percentage of them that are very hyperactive? It's really only about 15%. So the highlight was on them, though. It was first reported in 300 AD, or actually 300 BC, and the report was of wild overactivity. Okay, and that's the most common thing that you can see from the outside. But if you look closer, the most common and persistent symptom is inattention and difficulty with memory organization, working memory, and things like that. Another definition is a specific developmental disorder seen in both children and adults that's comprised of deficits in behavior inhibition, meaning that you don't have impulse control and can't keep your activity down to a minimum, and sustained attention, resistance to distraction, and regulation of activity level and demands of a particular situation. That's Russell Barkley's definition, who is a noted psychologist researcher in the area. So other definitions, the definitions are skewed toward children originally because as you may have, if you've ever heard me speak, you may have heard, or anyone else speak, you may have heard that we used to say when I was actually my first day of the pediatric clinic as a medical student, one little boy came in and he had turned 13 the day before, so the pediatrician in charge says, oh, he doesn't have ADHD anymore, so he's not going to be treated anymore. And I thought, he had it yesterday, he doesn't have it today? You know, and that was the way it was done. It was not treated after they turned 13. Okay, and then we went to, when I was in residency, we were going a little beyond that. Occasionally, if there was a really severe case. Then when I did my fellowship, we actually started, I was in Birmingham, one of the largest medical centers in the world, and at Children's Hospital, and we were starting to treat older kids. We had one patient who was 14, straight A student, had, when he turned 13, his medicine had stopped and he had a really rough time. We restarted his medication, became a straight A student, and for the next 2 years I followed him, and he did very well. Good athlete, good student, very good kid, couldn't focus and couldn't organize his memory to retain what he learned when he was off the medicine. So there are other names that have been proposed, like motivational variability or executive function disorder, and we'll talk a little more about that. But motivation, I'll mention that because I don't think I have another slide about it, but motivation is a big problem. One of the patients I saw last week is about an 11-year-old boy who's in a small school out in the faraway place, maybe a couple hours away, and the teachers have kind of pegged him as being lazy and not wanting to do his work, not having any motivation. He's actually grown a little bit, and he's outgrown his medication dosage, and he can't focus anymore. So we had to adjust that, but the teachers now have him pegged, and even after we adjusted and he's doing much better, they still see him as lazy, and they've given him that reputation now, and it's really hard for them to change their mind about him. And so, and they interpret everything he does as being lazy, trying to not do things he's supposed to do, and he's really doing them now. His mother verifies that he's doing things he's supposed to do, but they are still not wanting to accept that it wasn't his intention to be lazy and to be resistant to doing what he's supposed to do. So across the lifespan in the U.S., and by the way, in the news media in the past, because of the Church of Scientology input, there's a group that puts out misinformation regularly on a kind of a planned out basis about ADHD. There was a media campaign on their part to show that ADHD was strictly a U.S. type of phenomenon, and that U.S. phenomenon was that no other countries had it. Well, they have it in Britain, they have it in Germany, they have it in every other country, they have it in Israel, they have it in Japan. It's not just here. They have it in Australia, New Zealand. You know, I have friends in all those places who are ADHD specialists, and they work on those in those areas, and they're, you know, the research shows that it's prevalent in those areas. In areas that are very, very poor, they may not, even in the U.S., we may not see it diagnosed very much, because you know, as the community is poorer, the resources to actually have available diagnosis are a lot less. But in the 8 to 15-year-old age group, we see a prevalence of about 8.7%, and persistence of children with ADHD who have been treated consistently during the past year is only 32%. That means that in the past year, out of the 8.7% who have it, only about 32% have been treated continuously in the past year. Okay? A lot of the older research from the 90s showed that about 25% of kids ever got the diagnosis who had it, and out of those, only about 20 to 25% ever got treated. And out of those who got treated, a lot of them didn't get treated adequately. So it's really still fairly undertreated and fairly underdiagnosed in most countries. So, and the prevalence among 18 to 44-year-olds actually, in one study was 4.4%. So the percentage of adults with ADHD who received treatment, you know, of that group was only about 11% in the 12 months of the study. So most people are by and large not getting treated, you know, consistently or adequately or sometimes at all. It's associated with a high degree of psychiatric comorbidity, which means that, especially in adults, if it persists, you'll tend to have developed other problems, maybe depression, maybe you know, chemical dependency is a major one. So we'll see that as a major risk factor for addiction. And what I say is that they will, if you don't treat them adequately, they will find their own treatment. And it's not going to necessarily be a good thing. Usually it's going to be with alcohol, marijuana, or something else like that. It's associated with impairment in multiple domains. So it's not just like a school problem. When I first started in medicine, we treated ADHD for the school day only. So parents would bring their kids in to be evaluated. They get, if they had ADHD, they were put on medicine, and then the parents would bring them back, and you'd ask the parents, so how are they doing? They said, I have no idea because I never see them on the medication. They only give you medication for the school day and not weekends and not evenings or anything like that. Well, ADHD is something that doesn't go away, and it's at home and at work and at play and at school. It's a 24-hour-a-day thing, you know, so it's not necessarily something you should stop on weekends or holidays or summers. It's associated with a chronic course, which means that the numbers on this are kind of difficult. One of the major researchers that did a 29-year study found that initially that's where the 4% or so came in of adults have ADHD. But when he looked at his population, the percentage of those who had it as children who still had it as adults, the first study was done by phone. And when you talk to the patient themselves, they often didn't realize how much difficulty they were having. So they gave negative reports, and they looked like they didn't have it anymore. Then when they did a follow-up of in-person interviews with them and one other objective observer who saw them in their life, either a boss, girlfriend, boyfriend, or parent or sibling or someone like that, it went up quite a lot because they realized that those phone interviews were not really capturing the number of people who continued to have problems with it. Now, did they all meet criteria for the diagnosis? A fair percentage did not, because they get a lot less overactive, and they may have developed coping mechanisms that helped them to work better, but they still had significant symptoms and still had lots of difficulties with different things. Life was much more difficult for them in lots of different domains. And so that's how it looks, you know, over the lifespan. We used to say it never really goes away, because some of the neuroimaging I'll show you in a little bit indicates that it probably doesn't go away in very many at all. We used to say never. We said, first of all, it goes away at 13, then we said it doesn't go away at all. Now we say maybe there's some people that it does actually kind of go away in, but it's not a real high percentage. DSM-5, I don't know if you know what the DSM is. It's a diagnostic and statistical manual for neurologic and psychiatric conditions. And the DSM came through the 1, the 2, the 3, the 4, now we're on the 5, the 5th edition of it. It changes every maybe 7, 8, 10 years. And the DSM criteria originally only pertained to children. And this is the first of the DSMs that, number 5, that actually has criteria that sound like adults, like running, running and cutting in front of people in line. Adults don't tend to do that as much, although there will be some, but not usually that much, and things like that. So a lot of the wording was not really consistent with adults who needed to be diagnosed. So the change there was that they require only 5 out of the 9 criteria instead of 6 out of the 9 criteria for either impulsiveness and overactivity or inattentiveness. And those are a change that allow more people to be diagnosed. Also, there was a requirement that you had to have significant symptoms before age 7. How many of you remember in detail what it was like for you before age 7? Most people don't. Some people don't remember what it was like before age 12, but that's the new criteria. The new criteria is age 12. And it doesn't mean you have to be diagnosed, but there should be some symptoms and signs of ADHD present before age 12. It's not something that just appears out of nowhere. Usually there's a family history, and usually there's, when you look back, they had an eating disorder patient one time that came in with an eating disorder, so that was obvious. That's what she came in for. And after I'd seen her for several months and everything, it became obvious that she was having a lot of trouble with focus and attention. And so I said, did anyone in your family have ADHD? And she says, no, but my nickname used to be ADD. So, she was obviously pretty disorganized and everything, and it was, interesting to see that. But, ADHD is very stressful and it can contribute to other conditions. So you can, if it's not treated, it's very stressful and may cause anxiety to be really pronounced, or it may cause depression to be pronounced, or things like eating disorders and all can all be part of it. Obsessive compulsive disorder can be much worse with it. So another change that was that in the past, if someone had a diagnosis of autism, then that excluded the possibility of having ADHD. Well, we know that's really not true. We can see neuroimaging evidence of both autism, and we can see it of ADHD. So they're two separate things. They do have some overlap, and there are some people who believe there's more overlap than not, but they're really two distinct things, but they often occur together. And then, the news media makes a big deal out of increased stimulant production and usage, which as we included adolescents in our thinking of treating people, and eventually included adults, well, you will have a far greater number of people being treated. So that will increase the production. And then with these criteria, we may see an increase in the diagnosis as well, but it's going to diagnose people who previously wouldn't have met criteria, but really should have, because they were having difficulty. And another requirement used to be that you had to have severe dysfunction in 2 domains of life. So if work and family life, or school and family life, or school and work, or whatever, now you really only have to have the dysfunction in one of those areas. And it doesn't have to be severe disabling dysfunction. It's just significant difficulty, because if you have significant difficulty, you're going to continue to have difficulty. You're going to have to struggle to continue to perform well enough to be successful, and that continuous struggle is something that ends up with causing anxiety problems, depression, and things like that, or chemical dependency. Right. Executive function is, for adults who have it, is a really big part of it, and understanding it can help you out. Executive function has to do with using your brain for a lot of different things, but activation is one of them that is common for adults. You may have the idea you want to get up and go out and mow the grass, but you can't push that button in your brain that gets you up off the couch and to go and do it. So you can't initiate or get it activated. Focus is part of that too, but focus on planning out what you're going to do. So if you just jump up and walk out the door to mow the grass, but you don't have any idea whether you have gas in the mower, you don't have any idea whether how you're going to go about doing it. You're not dressed for it. You're not you don't have whatever you need for it. That planning thing, focus is part of that. And then the effort that you put into it, you may tire out too soon. You may have emotional lability because of it, because you haven't planned it out, and it's really frustrating. And the working memory is part of that too, because you have to execute a plan, you have to have the working memory that the plan is in your memory, and you can sequentially go through it. If each time you finish one little part of the plan, you have to go searching for what's the next part, then you're going to get derailed, and will probably not be very efficient. And at some point, they just give up, and they just kind of go sit on the couch again. And then the action brings us back around to the activation. So you actually do the activity and get it done. The role of neurotransmitters has been key in this whole process. And dopamine is one of the main neurotransmitters. We know that. We realize now that norepinephrine also has a big role to play. And we didn't really think that serotonin was as much of a role as it is, but it is. Dopamine probably is still the most important one, though. Dopamine has to do with working memory, motivation, clarity, true focus, but it also ends up working on memory organization. Memory recall can be augmented by norepinephrine too. It can be made more prominent, and we'll talk about some of those areas as we look at the neuroimaging. And then here's another Calvin and Hobbes. Look, it's almost 11 o'clock. Now the last 2 hours really flew by. I hope the teacher didn't say anything too important. And that's really, it shows that the time sense is one of the other things that people have trouble with. If something is really boring, then it seems like it takes forever to go by. If it's really exciting, it can go by very quickly, and so that's where if you have a teenager or an older kid and they go to the neighbor's house and they're playing a game or something like that, and they think that 15 minutes have gone by, but it's already 3 hours, and they're late for supper, they're late for whatever, but they really didn't. They may have realized it, but they probably didn't, because time went by very quickly. On the other hand, if you're daydreaming, it can go by quickly too, because it's like you're sleeping with your eyes open almost, and you may not know where that time went, and you may not know even what you were thinking about. So how long does ADHD last? Like I said, we used to say it stopped at 13, then we said it doesn't go away. Now we say it does go away in some. And I'll show you, I think I have a slide on this too. Some of the neuroimaging that just came out in the last year or two shows that there are individuals that normalize the brain areas that were under functional and under volume actually will normalize in some individuals, and they have a lot less symptoms, and they may not reach criteria or even have anything significant. It's a small percentage, but it is some, and it is hopeful. How common, and we talked about that a little bit more. What are the consequences, though, if you don't treat ADHD? This is probably a really important thing to understand, because initially we treated, like I told you, that we treated ADHD only during the school day, not on weekends, holidays, summer. And what we found was that, first of all, they treated it like the ADHD medications were highly dangerous and highly, something really bad, so we didn't want to use them any more than we absolutely had to. And I'm not saying you should just put it in the water supply, but at the same time, you look at each individual patient and you treat them appropriately, and you'll find these things that you see up here will be a lot less. So some of these are like ER visits, 33% more than the non-ADHD population, 50% more bike accidents, 2 to 4 times more motor vehicle accidents. And by the way, the motor vehicle accidents, they've quantified this too. They're not just more of them, they are more severe, like loss of life, and they're more costly. They do a lot more damage. And then you look at school and occupational experience, 46% expelled. This is a clinic population, so it's not exactly quite that bad. But, and when I say clinic population, that's out of all those in the clinic who had ADHD or some other condition. But 35% dropped out, and this is really probably true. And a lower occupational status is their income and their occupational achievement is quite a bit lower than their peers. Even though their IQ and their actual ability to do things is maybe quite good, they're still going to be a lot less able to do it. Substance use disorders, by the most conservative one, is 2 times the risk. We probably think it's more like 4 to 6 times the risk, because that's a major risk factor for ADHD developing, I'm sorry, for substance use disorders like alcoholism, marijuana use, cocaine use, methamphetamine. Early onset, and they have a much harder time quitting unless they're treated. Families, 3 to 5 times the divorce rate, 2 to 4 times the sibling fights and discord. And then employers, if you're a parent of an ADHD child, you're going to have more absenteeism. But as an ADHD adult, you'll also have more absenteeism and quite a bit less productivity and quite a bit less ability to appear like you know what you're doing. I had one patient who brought his daughter in years ago, and he had, was telling me the history. He'd been working at the same plant, though, for 9 years. Never got a promotion, about 120 employees or 150 employees. Never got a promotion. Still working at the lowest level. But in bringing his daughter in, she really had the diagnosis. Several family members that he didn't actually know, didn't think of, had the diagnosis also. And he came to me afterward and said, I have the same thing as her. And so he came in for evaluation. We evaluated him. He got started on medication. Within 6 months, he was in the number 2 or 3 spot in the place. They liked him. They just didn't think he was very reliable. He gave the impression of not being reliable because he was, just didn't seem like he had it together. And once you got it together, that's kind of dramatic. I won't say it'll happen for everybody, but if you're working hard and you're trying your best but not making any progress, that's real discouraging, and a lot of kids will find it easier to give up in that situation. Adults too, for that matter. And this one, you might have to turn it down lower for this one too, but yeah, I think you can see it. The colors are not so great, but the original, I'll just show you. These 2 people, one of them has ADHD and one of them doesn't. The way you read this is the white is very high brain activity. Red is high but not as high as the white. And this looks like green, but it's actually blue, is low activity. And this dark blue is really low activity. And this around the outside is just artifact. It's actually a violet color. So this brain has a lot of the green, which should be blue, but green and dark blue, it's low activity. This one has a lot higher activity. And so this one's more active and this one's less active. Which one do you think would have the ADHD if you had to guess? Okay. Most people will say this one. It's this one. It's a trick question, but understanding why that is really helpful. This one has everything this one has. This could be the same person, off medicine, on medicine. Okay. You have systems that are not turned on. Okay, and when I was first in medicine, they said, well, stimulants, if you don't have ADHD, they'll make you sleepy. And if if you don't have ADHD, they'll make you speed up. And if you have ADHD, they'll make you slow down. And it's not really true. They just help these systems that regulate your behavior to turn on. So it's like flipping a switch. So when you have the right amount and the right type of medication, it could look like this, because the systems that are turned off get turned on again. Now, what systems are those? There's one system that helps you to filter out distractions. Right now, I can hear some air handlers over here. Someone might be turning a page or something like that, shuffling feet. Birds might be singing outside. We can't hear them in this room, but in a classroom you can. And all those things might come in at the same priority level as what the teacher talking, for instance, or whatever else is more important. And they don't have a way to filter that out, so the filter is not turned on. And that will cause them to get off track multiple times for an adult or a child. Then another system that's not turned on is a perseverance function. When you start off on a task, you will get a little bump. It's an urge to continue on that task until the task is completed. So when you're trying to start off on a task and you don't have it's not turned on, you'll start off and then you notice the whatever it is, squirrel, whatever. You notice something over there. As an adult, you notice you start off on a task and you notice that needs to be done too, so you go do that for a while and you're not finished the first one, then you notice something else, and you go do that for a while, and then usually adults work in circles if they learn how to deal with it, so that they do a little bit on that one, then they go to that one, then they go to that one, and they may come back to the first one, do a little bit on that one, eventually they get it done, maybe, or maybe not, So, but they get distracted. So if that perseverance function is working, then you'll get a little nudge to stay on task. You try to get off task, you get a nudge to get back on task. And you end up finishing a task before you move on to the next one. And the urge goes away. Okay, and that really is helpful. Then another one is the memory organization function, which the way it works, this is oversimplification to some extent, but this is how it really seems to work, is that when you learn a piece of information, it's like writing it on a sheet of paper in your brain, writing it down, and then you have a sheet of paper that you have to put into storage. Okay, so if you have it turned on, if you have that system turned on, you get a file system with folders A, B, C, D, and so on. You put those sheets of paper in those folders and you can pull them right out, math, history, English spelling, whatever it is, and you can pull it right out to use for a test or to build on it. If you don't have that system turned on, you get a cardboard box. Okay, the cardboard box is everything, all the sheets of paper go in at random. How many of you have a pile of paper somewhere in your house? Okay, if you look through that pile of papers, it's not going to be easy to find what you're looking for. And so when they look through the pile of random papers with information on it for a test, they'll say, I know that, but I just can't think of what it is, And we all do that. Sometimes we all do that here and there, but it's often, and it ends up costing them a lot in grades and performance. So when that system is turned on, you get that ability to organize that, and you can it'll stay organized for years. And when kids begin high school, what they learn and what they retain becomes really important for ACT or SAT, where they get to take a test which will determine how much financial aid they get or whether they get into a college or not. And so it becomes really important to retain. Plus, it's very frustrating if you knew this material and you have to go back and learn it all over again every time you come up to it in years, several years of school to come. So it's really important to have that knowledge there in an organized way. The other two relate to overactivity and impulsiveness. There's an impulse filter. When you're little, you walk up to somebody and they've got funny looking hair, and you might even say, you got funny looking hair. But then if you get their reaction, it's not so great. They don't like being told that. So you learn to kind of stifle that that impulse to say that. You get if you have the system turned on, you get a split second to decide, okay, I'm not going to say that. If you don't have it turned on, you don't have the split second to decide. It just pops right out of your mouth. So the gumball, just shoots out of your mouth and you can't take it back. Not really. So that's the impulsiveness. Or pressing a button or something like that. You just do. For teenagers, they may pull out in front of somebody, impulsively, things like that. They can have bad consequences. The other one is motor overactivity, which motor overactivity is like an example of that. It's more whole body activity in younger kids. Like they may be 6 years old in class and they go to the pencil sharpener and they don't even have a pencil. They don't even know why they went to the pencil sharpener. The teacher asks them, why'd you come here? And they say, I don't know. And the teacher thinks they're being smart or whatever, but they really don't know. Their body got up and moved to the pencil sharpener without their permission. And it's just random movement. So we end up with the situation where they're not in control of the behavior. As they get older, they shift to things like clicking pens or tapping their feet or other things that annoy people around them, but they're not as as much of a disruption to the whole group of people. Okay, and those things don't change. Don't change much, at least. In this particular study, this was a 38-year-old father of a 9-year-old boy who was diagnosed with ADHD after this, but his son was in part of a study and they couldn't use children yet. They were standardizing PET scans for children, but he had the same appearance. The mother had the same appearance, the son did too, and in all the studies since then, 80% of the siblings have the same appearance. Now, will 80% of the siblings need to be treated? Not necessarily, because if they don't go far enough in school, they may not need it. And when I taught at UAB Medical School, I taught 3rd and 4th year students, and a lot of them, remember, we were not treating adults quite yet. We were getting closer, but not quite yet. A lot of them did really well in the first 2 years of medical school where you're just looking at books. Then when you had to use the book knowledge and had to remember all kinds of things about the patients you were seeing, they just started sinking. And we had students that had reached the brick wall, as I call it. You know, you have, if you have this much concentration, and 1st grade requires this much, 2nd grade this much, you know, you sometimes, at some point you pass up the amount of concentration you have, and then you're going to have a very hard time being successful after that, you know, with more complicated situations. So you end up with a situation where you really try as hard as you can't make your concentration work well enough for you. And some of those students dropped out. Nowadays, those students get treatment and they can go on. But those who are in a family that they never get past high school or never get past college, they may not ever see that situation they may not reach that brick wall where they can't go any further. Okay, let's see, I think that's, and what they found was also, this is interesting and may be helpful to some people too, is that if this person was, let's say he's the 10-year-old or 9-year-old, he's playing a video game, you'll see a lot of it look like this. It normalizes quite a bit. So they titrated, they said, okay, good, we'll put educational material in video games. They did that, and they found that if once they got around to 11% educational content, it started losing its effectiveness, and then when they went on by 13, 14%, it didn't change anything anymore. They lost their interest in the game. So it doesn't work that well. And they've tried it with fishing games. I'm not sure if they tried it with shopping games for women and men too, but other things like that, if you're really excited about it, it may turn some of these things on. You just can't make someone be excited about something they're not excited about. So if it's math and they just struggle with math and they really don't like it, it's not fun for them, and they have concentration difficulty, you're not going to be able to turn it on very easily at all. You know, naturally, they'll need some help with that. What's the purpose of neuroimaging? Because there is a little confusion about this. And there are people, at every step of the way, there are people who take advantage of people who are desperate to find some kind of help. And there's a group there's several groups who do neuroimaging and provide really beautiful images, but they're not necessarily diagnostic. At this point, the neuroimaging is driving our research, which helps us to see what the causes of ADHD are in terms of the neurotransmitters and all that and structure of the brain. But it also helps us to see the effects of medication, and it helps us to see how to develop new medications that may work that are totally different from anything we have now. And not that what we have now is really bad, it's just that it doesn't work for 100% of people, and we would like to be able to help those people that are not being helped right now. And so at this point, they're not meant to be diagnostic. I've had a number of people go to different clinics where they spent anywhere from $10,000 to $25,000 getting some beautiful neuroimaging pictures that really don't mean very much. And they tell them at the end, go back and see your doctor and and just let him treat you. We knew that before they went, you know. And there will be, there'll probably be something that's really diagnostic eventually, but will we need it to use it most of the time? Probably not, because the necessity for it, what we found out from the neuroimaging is that it confirms that when we do a clinical evaluation, it's really pretty accurate. You know, so it's not going to be necessary most of the time. But there are people where we don't know what we're dealing with because there's several different problems, and it might be helpful in that kind of situation. The There is I don't know if I have a slide on it too, there is something called the NEBA system EEG diagnostic tool, which it works on a beta-theta wave ratio. It doesn't mean too much to you, but it's an EEG brainwave test that looks at the ratios of different waves. And it's not, it increases the diagnostic accuracy of someone who doesn't generally diagnose it well or very much by about 13 or 14%, which is not a huge increase over, what they did was they got experts to go in and evaluate them versus a community doctor who added the system to it, and it increased their diagnostic accuracy by about 13%. But if so it's not really that much of a help, let's say. And the cost, every time you do one more test, it's an additional cost. So I'm not sure if it's available, maybe it'd be helpful, but it's not that helpful. And this is just an example of neuroimaging, also other types of neuroimaging, and that shows that these are relatively subtle differences. Like this one doesn't have any of the dark red, and this one is just this particular type of imaging is probably SPECT, although I don't think I have it on here. Yeah, I think it's a SPECT image, and that's using a tagged something tagged type of dopamine production, and it will cause it will show you increased metabolic rate and metabolic activity. So some of these things are pretty easy to see, but they're not totally diagnostic yet. Now, does ADHD decline with age? Yes, it does. The overactivity and impulsiveness do the most. Does it in everybody? No. I know probably everyone knows some hyperactive adults, so that it's not in everybody, but it's in most, that the hyperactivity and impulsiveness will go away. When does it go away? Sometime between 10 and 15 years old. Most kids will get a lot less hyperactive if they ever were. Remember, only 15% were very hyperactive to begin with, but they will get a lot less hyperactive. Sometimes either normally active, sometimes even underactive, like because of that executive function thing. So they just sit on the couch and just do nothing, or these days play video games. Why are they drawn to video games? Because they can do them well. They really turn on their focus, and it feels good to have your focus turned on and to be able to accomplish something, even if it is in an alternative world, that's not really real. And really, the proportion of adults with ADHD that have symptoms of all kinds, these are the ADHD symptoms, but difficulty remaining seated. Some of those, I guess adults have difficulty remaining seated too, though. But forgetful in daily activities, losing things, careless, sloppy, the blurt out answers could be for adults too, but it's more for school children. And the easily distracted, difficulty sustaining attention, difficulty completing tasks, all those are there, same as for others. And this is a slide that, this is a little bit more subtle, but if you look at, they do something called, something that measures the volume of the increased activity. And when you look at those numbers, it's three-dimensional, so you can't really see it on a slide. But when you look at those numbers, this is a patient with persistent ADHD, and these systems are not as turned on as these systems in the one with remitting ADHD. So remitting means that they have far less symptoms, and that they don't reach any kind of level of dysfunction. So they're not really, they know they have symptoms, but they're not really bothering them. Okay, and that's what the definition of remitting ADHD, it's kind of gone away. So we can actually see that there's a reason for that. We used to say that if people didn't have symptoms, then they were probably in their dream job. So they had a job where they had someone else do the paperwork, had someone else take care of the organization, and they just did the creativity or the things that they were highly interested in, just really enjoyed a lot, and that helped their focus stay tuned in. But now we know that there are people, there's evidence, physical evidence, for the fact that people can remit. It's just not a high percentage at this point that we can tell. So a lot of these things, these are kind of the emotional, long-term emotional consequences, maybe impatient, quick to anger, easily frustrated, overreaction, tendency to overreact emotionally, easily excited, lose their temper, easily annoyed. There are others too, but those are some of the main ones. For ADHD kids growing up, that's these are common. You may not have any of these, but these are common consequences. And then we talked about the consequences of ADHD before on a different slide. Accidental injury is probably the worst one because the number one cause of death from 44 years old down to about 4 or 5 is accidents. And automobile accidents are the worst because you got a lethal weapon that you're putting in the hands of people who are having limited concentration. The number one cause of traffic accidents for ADHD individuals is not impulsivity, although they can pull out without thinking sometimes, but it's usually looking away from the road, and that reminder system that kind of nudges them to look back at the road, it's not working, it's not turned on. So if they look away from the road, they can be looking away for a very long time. Last time I gave this lecture, I told about my patient who lived down in Cameron Parish and was going for maybe 16, 17 years old, was driving back down there after and had bought a hamburger on his way out, and he was turning onto the 7-mile straightaway that Highway 14 goes to the east in the middle of that. And he opened his sandwich at the beginning of the straightaway and hit someone from behind. Wasn't a bad accident because they're both going almost the same speed, but hit someone from behind at the very end of the straightaway. And he had stayed on the road with his peripheral vision, but he'd never looked up from his sandwich that whole time. That's like 7 miles, so it had to be about 6 or 7 minutes that he didn't look up, you know. And the other car had turned on after he was already on the straightaway and opened his sandwich, and it was going a little bit slower than him, so he caught up with it by the end of the straightaway and hit the back of it. It wasn't too bad, but they were able to stop and everything. But it just highlights how long they look away. I've had other patients who looked away. Someone else was in the car with him. They looked away. A curve came up, went off the curve, and were killed. You know, so it's really a dangerous thing. So we definitely recommend having medication on board when you drive. That's a big one. This one pertains to judgment, and judgment is one of those things that is we commonly think of judgment as maturity. Used to be that when someone brought in a first grader or something like that, they said he's just so immature, he's just really like a 3-year-old or whatever. The teacher wants to just hold them back because they're immature. And what the problem was really more judgment and control. So they would be impulsive, but they also had poor judgment. They would do things that didn't show good judgment. And that made them look less mature. Well, when you get to 14, 15, 16, 17-year-olds, they still may be having some problems with judgment. And typically judgment develops over time. You see the 5-year-old brain, the prefrontal cortex is part of where a lot of that is developing, and this is the maturer brain. At 20 years old, we're not all the way there either, and you can see that the transformation over time. We really see a significant amount of development. I call them brain upgrades. You know, you're going to get brain upgrades all through the 10, 11 on up to, we used to say 25, but it's actually up to 30, and some recent research showing that the brain actually still, you see structural and like what amounts to hardware upgrades on a computer up to about 30. So you've got that happening, and they can do things they couldn't do before. But judgment is one of the areas one of the last ones to really be completed. And by the time they're about 20 or 21 or 22, their judgment is closer to what it's going to be for the rest of their life. Not necessarily all the way there yet, but it's much closer. On the other hand, if they have ADHD, autism is very similar to, they might be up to 30% of their age, and could be more, delayed in developing certain areas, with judgment being one of the main ones. So we might still see some difficulties with judgment. That's one of the reasons why it's really very good to not have people legally be able to drink and do different things like that. Why, if they wait to start smoking, ADHD kids are the first to start smoking, and they have a much harder time quitting. But if they can delay it, they have a much better chance of not starting it to begin with. You know, so that because the judgment and some of the other areas get better. and more functional in time. So there are lots of different areas that are delayed, and I won't go into all of them. You know, girls and boys both follow the same patterns. This is one of the, this is an interesting thing, is that the size, there's temporal lobe size reduction in ADHD, and there's frontal lobe size reduction in ADHD. And those are looked at volumetrically, and you have to, it's hard to show you, it's a three-dimensional thing rather than a two-dimensional thing that you can see on a slide. But we know that the size of those areas, which have to do with judgment, have to do with maintaining, doing what you need to do, staying on the task and things like that, those are actually smaller. One of the most recent, and I don't know if I have a slide of it in here, one of the most recent things that that's come out is that in the neuroimaging area is that you're with treatment, with stimulant treatment specifically, the brain volumes tend to get more normal. There was a big concern about whether if you treated with stimulant medications, you would first of all, years ago before we had any of this imaging, they said, well, it'll be a crutch and they'll get hooked on it and they won't be able to stop it. You know, they'll need it forever. Well, the truth is they may still need it forever, but not because of that. It's because they still have the condition, potentially. You know, so they may need it. I never tell anyone you're going to need to be on this medicine forever. I just say, probably through your school career, you'll probably need it. And then you can make the decision after you get out of school. You can see how it goes, you know, see what it looks like. But many will need to continue it. But the thing is that we see, you know, we were concerned that we might be damaging the brain in some way, you know, and that does not appear to be the case at all. It looks like we actually normalize. What we said before we had in the imaging is that we know that if you have the ability to organize your memory, then you will internalize things better. So kids who are on their medication regularly will tend to internalize family values much better. So over the long term, you know, they spend time with their family in the evenings, on weekends, holidays, summertime. Those were the times they didn't get treated in the past. And a lot of times they were with the family, but they were staring off into space and didn't hear anything that was being said. You know, so if they're able to connect with the family better, they're probably going to bond better and internalize family values better and be more present in the family rather than just being kind of, you know, off in their own world. So it's another reason why I think it's really important to treat it more than just the school day or, you know, the school week. So untreated ADHD, let's see if I can get this to come up, is, you know, they're 3 times more likely to smoke every day, 2 times likely to get drunk in the last 6 months, 3 times more likely to use illicit drugs, even beside marijuana. And the greatest risk is accidents and injuries, higher incidence of depression, anxiety, increased amounts of legal troubles, interference with peer and family relationships, and it's a really big one for the long term. Okay, a little comic relief. Patients with ADHD always have funny stories. They're doing different things. This is one that one of my patients that decided to go parasailing. Okay, this is what parasailing should look like. Usually it's done in a broad area of body of water. This is what the patient had. And this is the boat. And they had a parachute which was tied with little strings, and that they bought, and they had the parachute, all the strings were cut off because it was used by kindergartners to flow in the wind and stuff like that. Well, they tied an anchor to it and got in the boat, took off. The anchor was going to be their test passenger, and they went off into one of the little bays around here that's kind of shallow, dropped the anchor, and it stopped the boat dead in the water, and it, you know, shot one of them out. And so they do things like that without thinking. So that's executive function to some extent in planning what could happen if I do this, you know, like the redneck joke, you know, watch this. That's the famous last words. So anyway, you'll find them not knowing, not looking at the consequences of what, and not seeing the bigger picture of what's going to happen. So also consequences are failure, school dropout. Some of these we've talked about, and risk of undertreatment. When do kids try marijuana for the first time? What's the most common way that they try it for the first time?
With their peers?
Well, with peers, but and when? Evenings, weekends, and holidays, and summertime. Summertime is probably the most common. A lot of them start over the summertime. Okay, so those are the times when we didn't treat in the past, but it's really important to treat them during those times. They may not need the full amount that they need during school time, but they do need some. And relationship risks are related to a lot of different things, and we've talked about a lot of those already, but the ADHD treatment actually helps with those. What are the sexual risks? ADHD individuals who are not adequately treated, and really it's the ideal treatment is most of the waking hours, 7 days a week, year round. If you don't, but it needs to be tailored to the situation, because summertime they may need less, or weekends they may need a little less. And if they take the regular amount, it may feel like a little too much. So we want to be sensitive to that and adjust it accordingly, but it does help. So the sexual risks, though, are they will do things impulsively sexually to get themselves exposed to things like HIV or other kinds of sexually transmitted infections. In addition, the difficulty with increased pregnancy rate. Several of the studies show that boys with ADHD are something like 58 to 60 to 75% more likely to father a child unintentionally. Girls maybe 25% more likely than their peers, or at least, let me put that differently. A 5-year study looked at those who didn't have it. They had a 1.2% pregnancy rate. The ones who were treated 7 days a week, most of the waking hours, year-round, had a 2.4% rate. The ones who were treated mostly on school days, they didn't really take it on weekends, holidays, and stuff like that, and the ones who did not get any treatment whatsoever had the same rate, identically, 25%. So it's quite a big difference.
The person has ADHD. Does that mean when they're poor planners, that they're always going to be late for their appointments?
Well, part of being late for appointments is time sense, because they don't plan that out either. So for most of them, if you ask them, well, what's your target to leave for the appointment? Well, my appointment's at 8:30. I'll leave at 8:30. Okay. The other thing is that they will think they look at the clock and they really need to leave at 8:15, and they plan to leave at 8:15, and that would let them get there in time. But at 8 o'clock they're ready, and so they sit down and look at the YouTube video or 2 or whatever, or 5 or 6 or 10 or 12, and it's 8:30 before they realize, I gotta get going, you know. So they'll do something. Their time sense doesn't, the reminder's not going on, you know, to urge them to go, and their time sense is not very good either.
Is it something you can say to them to help them to become a better planner?
Well, one of the things that we can do, let me go on with some of this because I want to get past a little bit of this. I think we talked about some of these. I tried to get rid of the animation and I can't figure out how to do that, but so one of the things is, you know, medication does help some, but what helps more with that is to get in the habit of planning is to have someone help them with coaching. And I've got some of the slides on coaching. Let's wait till we get to that, but let's talk about medications for a little bit, and then we'll talk about some of the non-medication things we can do, which includes coaching. Medications, are they safe? They have been around since 1950 or so, 51, 52, 53. Some of the major ones came out then. They've been out continuously. People have taken them continuously. We don't have any evidence of long-term side effects. Every now and then someone comes up with, you know, I remember this one well, but the front page of the newspaper, this was back before the internet was as popular, but it said that the new FDA study shows that Ritalin causes testicular damage. I had about 1,000 phone calls in my office. And I looked at the study and it didn't look like anything the FDA would ever do. So I said, I think this is not an FDA study. This is part of that group that puts out misinformation. And sure enough, there was a retraction about 2 or 3 days later in the back page. But this was a big front page, you know, article. And so we really haven't found anything like that. You know, no long-term side effects that we know of. So some of the ones that we have thought of, one of them was the heart risk. But the heart risk, you know, the main heart risk study was about 3 million patient years. It showed that there were, if you were on Adderall, you had I think there was 1 per 3 million patient years sudden cardiac death. If you were not on it, there were 3. Okay, they didn't report that, but that's really random still. It really means it's not happening for the most part. You know, it doesn't have anything to do with the medicine. It's like how many people ate bread and had sudden cardiac death, or milk, or whatever. You know, it's not really related. It's not very, but that's something that happens no matter what in young people for reasons that, you know, various. How about growth? Growth typically is normal with the stimulants. You may see a little bit of decreased growth. I think that's when you first start, I think that's mostly artifact. I'm not sure why that is, except that their growth may not have increased yet. But typically, what I see in practice is that if someone is untreated, and I'll have patients that come to me like that are 14 years old and they're really small, and they've had trouble with ADHD all their life, but they've never been treated. The constant stress appears to delay their development and their growth. You know, so that so if you help them to get to their best level of function, then they tend to do better, and we end up seeing a lot of improvement that way. You know, so so those risks, tics, they actually, if you do it right, the net effect is decreased tics. The stress increases tics this much. The medications increase it that much, pretty much, and that's temporary. They usually get used to that. And then seizures are not a reason not to give it if they're well controlled. And for adults, high blood pressure is not a reason not to give it if it's well controlled. But you want to have those things under control. That was the study, by the way, about, you know, increasing cortical thickness in those who have been treated with medications. Let's look at yes.
If a patient is taking, in an adult person with ADHD, they're taking medicine for hypertension or some of the statins,
Mm-hmm.
does these medications have an adverse effect?
No, typically not at all. They're related to the decongestants, but they actually don't have much blood pressure increase at all. The decongestants have more. The ones that we think of, phenylephrine and Sudafed and things like that, have more effect on blood pressure. These tend not to do that. And once you're controlled, you can use them with no problem, really. And then, so our main principle for medications is that they improve brain function. Okay, it gives you a baseline improvement in brain function. If you have that baseline improvement, then they can often figure out how to do things the way they should. They'll often develop the way they should, and all. But if they don't have that, then they're developing at a real handicap. They're not able to internalize things. They're not able to figure out how to do things, and life is pretty difficult. Everything they do is kind of messy and slow and tedious, and it's difficult. So what we want to do usually is to try to begin, if they have a diagnosis, we want to begin a medication at a low dose, find the dose that works for them. These are threshold-related medicines. They will, you know, if this is the threshold, we don't know what it is for an individual. Automatically, we have to find it. So you start low and you find, when you reach it, just below it, you won't get much improvement. When you reach it, you will see a big improvement. So if you're just above that, if you get too far above it, that's where you'll see overfocus type side effects, where they're just either too focused and they can look at the wall for 5 minutes, and you know they're contented to do that, but we don't want that. We want them to be able to function well. So you have to find the best dose, the optimal dose.
Sir,
Yes.
have you ever treated a set of twins that had it?
Mm-hmm. It's real common.
Really?
Yeah,
It's common?
very common. They may not, though. If they're fraternal twins, especially, they may not both have it. But siblings, remember, siblings have an 80% chance of having the same appearance on the imaging, so they would be likely they would both have it. So now you want, with ADHD medication too, that each one of them has a particular lifespan, and you need to cover or treat consistently throughout the day. So you know, if it's a 12-hour medicine and you have an 18-hour day, like some college students do, you need to cover that part of the day. If it's an 8-hour medicine and you need to cover school and evening time, then you need to give something to boost that after school. You have to try to figure out a way to cover the times of the day you need it covered, which we recommend most of the day, the waking hours.
I wanted to find out, does schizophrenia have anything to do with ADHD?
No, not directly at all. It is another hereditary, condition, neurologic condition, but it doesn't. It's a neurologic condition. That's about what they have in common, though. They're not in the same parts of the brain exactly. Although someone with a schizophrenia exacerbation will not have good concentration and stuff, but it's really just during that time. Yeah.
Are any of the drugs that you mentioned here for ADHD time released, where you
Yes.
can stabilize?
Right, and they're in your handout. It'll be in there. This is slowing me down, but the longer acting forms are the ones that work the best in general. Okay, nothing's everybody. You have to individualize it to the patient, because some people just respond to different things better, even though it doesn't make sense. But usually, longer acting forms are preferred because they're smoother. They don't have to remember to retake it, which is really difficult, because like one patient told me last week, if I could take my ADHD medicine, I would remember to take it. If I could remember to take it, I could remember to take it. It's, in other words, he needs the medicine to be able to take it. Now, at the end, I have a few slides that I probably won't get to at all, but about 12 different medications in development. 2 of them are medicines you can take at night, and they don't start till the morning. Okay, I don't know if they'll make it through the process of coming out.
What's the purpose of
The purpose of that is I have a lot of parents or grandparents that go to work at 4 in the morning, and they can't really wake up the child and give them the medicine then, but they could give it to them the night before and have it kick in about 7 in the morning or so, And then some kids would do much better if you could pick when you wanted the medicine to kick in the morning, and like might be 6:30, and at 6:30 they kind of wake up and are focused and they can get ready, and it's not a fight or a struggle. For some of those now at this point, tell parents to wake them up a little earlier, or if it's an individual, set your alarm for an hour earlier, take the medicine, then an hour later you're ready to get up. You can actually focus and push the button that gets you out of bed inside your brain. So other things about the long-acting medicines, you tend to have less side effects, and you have less of the, you're going to have compliance. It'll be much better than that. So drug holidays, I've mentioned already. We don't like to do drug holidays anymore. That hasn't been recommended for a long time because of one other thing. The not being able to focus is one part of it, and not being able to assimilate family values. But another reason is that if you stop the medicines for 2 days, when you start it back up again at the full dose on Monday, it's going to feel too strong. And they will say, I don't like the way it makes me feel. Whereas if they're used to it, if they stay used to it, then they can handle that much better. And they really, if they do go away for 2 days and don't have it, then you start off with half the dose for a couple of days the next week, the first 2 days, and they'll get used to it again pretty quickly.
Do they have negative, problems with it on the side? I mean, they might be not.
Like side effects?
Yes,
Well, the side effects will be, startup side effects go away in a few days. The problem is that if they stop it for 2 days, they get startup side effects again if they start at the full dose. They didn't get to that dose overnight. They worked up to it usually. So I'm trying to run through some of this to get to some of the other things.
I saw on your slide it said weight loss too below acceptable BMI.
Yeah,
That's one reason for the.
Yeah, and it's really that's really you have to look at the individual, because when I teach in the residency program next door, the LSU residency program, and when I have a resident who comes or a parent who comes in with their child and says they're losing weight on their medicine, the first question I ask is, are you taking it on weekends? And they'll say, well, no, I want him to eat on the weekends. So he eats really well for 2 days and then he eats nothing for 5 days. That's not good. Okay, so because it takes 2 or 3 weeks to get used to the appetite effects, if they're taking it regularly, very regularly, now they may only need to take half of it on the weekends, that's fine, but if they're taking it regularly, then they're going to get used to the eating side effects, and they may not still eat that well at noontime when the medicine is really in effect the most, but they'll probably do pretty well, for the day, both before school and after school. They'll probably make up for it, So you want to do that cautiously. Drug holidays, you want to do it real cautiously, because that's when they're more likely to have accidents when they're off the medication. So it's actually kind of high risk, potentially. Right. Let's see. Yeah, this is one of the slides I was trying to get to. With these are new. There's a lot of new ones right now, but they're really remakes of the old ones, and they may be useful in some. But these are options for extending coverage, just different medications. And I thought I had one that showed some of the, let me go back to this. If you look at this one, you've got like each one has a particular duration of effect. That one's like 4 or 5 hours. This is 8 to 9 hours. That's about 8 hours. That's about 12 to 14 hours. That's 3 to 4 hours. This is about 8 hours or so. This is about 8 hours. 12 hours. This could be up to 15 hours if you leave the patch on long enough. And Focalin XR is probably about 8 to 9 hours. Strattera could be 24 hours, or it could be 4 to 5 hours. It depends. It's real variable. And Strattera doesn't work in a high percentage of patients, but when it does work, it works well. And I wish it worked in a higher percentage, but it doesn't. But it can be used in combination with one of the ones above it. And that I've seen where some kids, they just don't get quite enough help from a certain dose of a stimulant, but to go up more, they don't feel good. So we stay low and add something like Strattera, and sometimes that really works well. It's more complicated, but what's that?
How about for adults? Are there any one
Yeah,
of those that
for it really, it's individual. So if someone in your family has had a really good effect with a certain thing, certain one, then that would be my starting point. Something like that, because genetically we're have some other slides on that too. There's no way we could get to everything, but we're going to be able to do genetic testing pretty easily. It might cost $50 or $60, something like that eventually. It's a little too expensive now, and it's not worked out well enough yet, but we will maybe able to tell by your genetics what you're going to respond to best, and also the dose range that might work the best. So far, it's not too accurate, but
Is that what that means in the column where you say maximum slash day or max? Is that
no, what that means is that this is the FDA maximum. The FDA does not determine the standard of care of treatment, okay? This is what came out originally at first, when it first came out, and so it was an original guideline. What happened is that after it came out, a lot of other study was done, and they found that these doses were safe and effective too. They're just not the official FDA doses. The problem is that insurance companies like to use these to limit what they'll give you, which is a big problem. So this is from the American Academy of Child and Adolescent Psychiatry that shows the maximums, which are a little closer to what we actually practice.
If a person was on Ritalin, say when they were 8 or 9 years old, and they're 50 years old now, should they continue taking some kind of...
At every point in your life, it's a decision whether that's something that would really be helpful or not.
Yeah.
There's not a problem with it though, with continuing.
But Ritalin has been around for a long time.
It's been around since 1953.
Yeah.
Yes, sir, Doc, can you go over those hours real quick again?
Yeah, 4 to 5 hours, 8 to 9 hours. 8 hours, this one's not as effective as this one, and they're almost the same. This one's 12 to 14 hours, 3 to 4 hours, probably about 8 hours, roughly 8 hours, 12 hours. This one, if you leave it on for 12 hours, it can be 15 hours, and it's a patch. And then Focalin XR is about 8 hours, 8 to 9 hours. And this one is real variable. It's hard to say. It could be 24 hours, it could be a lot less. Mm-hmm.
is the physician that treats child and adolescent ADHD familiar with or can treat adults?
A lot of them can and some can't. I remember going about 20 years ago to a meeting where we were all ADHD specialists, and I came through family medicine to adolescent medicine, and some of them came from pediatrics to adolescent medicine. And most of them in this group were pediatricians who were treating adolescents and young adults. And one person confessed that they treated an adult patient, a parent, who they said if they didn't treat the parent, the child would never get better because the parent was too disorganized and really needed to have some structure to be able to help the child. And then once that one confessed that, all the others did too. So pediatricians don't like to treat adults typically, but a lot of the family medicine doctors are better trained now to be able to treat ADHD in adults. Psychiatrists can do it too. Some of them don't get much training and some of them do. Depends on their interest level also.
Do you?
I do treat adults too, although my main group is younger people, and I treat adults with the residents, you know, in our residency program. Yes?
Do you find that there's anyone local that focuses on adults well?
Dr. George in Westlake is one that I think he's done a lot with them, and I'm trying to think if there's anyone else that I know of that specifically has a high interest. It's been, you know, it's really, I can't really think of anyone else right offhand that has a special interest in it, but a lot of people will do some. They just don't want to see everybody in the area.
Well, and I'm not sure that I'm not sure that they're all doing it effective. That some
Yeah.
the ones that are willing are doing it effectively.
Right,
The
and some,
concerns.
yeah, it's important for them to have an interest in it because then they'll probably try to learn more about it, you know, and that's so I think when someone moves somewhere else, especially they'll ask me, well, who should I go to? And I'll say, find someone else that has it too and see who they've gone to and who's been good for them, who's worked well with them and stuff. And that's usually the best way to do it. Although I wish I could tell you more, but a lot of the younger family medicine doctors do understand it if they're interested enough to do it is the thing. So non-pharmacologic approaches, and I'm sorry for having this at the end, are to you know, to modify the environment. That's one of them. And for schools, we want to do things like getting modifications and all. You know, you've got a classroom of 25, 30 people all making noise. It's really a difficult thing for them to not be totally distracted by that. So you want to do that. But on the other hand, accommodations, we don't want to dumb down anything, and we don't want to give them unfair advantage or anything like that, but we just want to level the playing field. I have one patient last week who who really has difficulty writing his words 10 times. He can do them 3 times and he remembers and he makes A's on the test, but he's losing points every time he can't get through the homework before it's time to go to bed because it takes forever to repeat things. And that's a common thing with ADHD. If you're repeating something over and over, it gets monotonous and your ability to focus on it just goes away. And it takes forever because you've got to keep pulling yourself back. So we recommend not doing repetitive activities over and over just to do them. You know, that does help some people learn, but doesn't help everyone. And really, if you do the best thing to do is to work collaboratively with the teacher. Like this particular child last year had a wonderful teacher who worked with him well, was patient with him and stuff like that, noticed what didn't work with him, changed that, and he did great. And this year, it's a struggle. So, you know, because the teacher says everyone should learn the same way and should do the same thing exactly, you know. And so it's difficult sometimes, and if they can work together, it's much better. Then you want to integrate the student with peers, not isolate them, and take the view that all students will do well when they can. Because a lot of times, like I was talking about, the school has the opinion that a particular student's not a good student. They don't want to do what they're supposed to do. Generally, I find if they're not doing what they're supposed to do, it's because they're having a really big struggle with it. If you help them with the struggle, most often they're going to want to try to do what they can do. It's much easier to choose not to do it, though, to give up and say, I'm not doing it, and you save face that way, than to try to do it and fail. So if they're going to try and fail, they may do that once, but they're not going to do it the second time. They're going to give up and say, I choose not to do it then. And you can't make me do it, you know, because they can't make themselves do it. So, so that's the thing, you know, is to stay positive about that and reduce distractions, you know, just instruction styles, facilitate following instructions. If you know that your instructions are really difficult, change them. Make it so it's easier for them to do it. And avoid overwhelming the students with eliminating duplication, allowing dictation of responses to parents or to, another kid I had that his handwriting is really bad. And there are kids who have dysgraphia. Now some handwriting, sometimes when you treat ADHD, the handwriting gets really nice, but sometimes it doesn't. That can be a separate problem. So you use other ways to do it. You can do, that they have iPads and computers they can answer on, and some kids, once you do that, they're making straight A's now because it's not that you're giving them anything, you've taken away that disadvantage they have in that they cannot write.
Dr. Soileau.
Yes.
Is there anything connected with handwriting that may be a tip to look out for? My 15-year-old grandson writes the strangest I've ever seen anybody write. He writes from the bottom up.
Yeah.
And it takes him forever.
It can be, that can be, well, it could be an autistic symptom, or it could be not, but I know they're if you have anything on the autism spectrum, it doesn't have to be the whole thing, but they could be very high functioning, but they will tend to see things and perceive things a little differently. Or it could be that that's the way he was taught, or that's the most comfortable for him. But can you read it?
Yes.
Yeah. Or it can be
Very small.
can be OCD type stuff, but it could be, it could be any one of those things. OCD takes them forever. It could be, although I'm not sure how that would work if it's really small. It should be bigger if it's vision. Usually they tend to write bigger because they can't see what they're writing. But it could be.
And he's very, very intelligent.
With true dyslexia, there's true neurologic dyslexia that really does exist, but the majority of kids who were diagnosed dyslexia 25 years ago really had ADHD, and it resulted in reversals and difficulty reading and retaining what they read. So I usually recommend that if you have someone that is any inkling that they have ADHD, treat that first. If you think they have dyslexia, then you can test them, and if they really have it, they have it. But you'll at least eliminate the false positives that you get from the ADHD itself.
What about if you're 70 years old? You ever be healed of that?
Well, we don't know that it goes away, but what you need, what you're trying to do in your life, is what counts. If you can get enough. I have treated people up to maybe, I think the oldest one was probably 79 or something like that. But so you can treat it at any age. It's not necessarily unsafe or anything. It's just a matter of whether you need or not. So accommodations, are those modifications and things like that. Then there are, tech things, like we have some patients that use like reminder systems, apps, things like that. Focus at will, rescue time, those are all, antisocial is one of those that helps them to decide not to spend too much time on social media and things like that. It's an app they put on there that kind of helps them monitor it. Sleep can be a problem. I like this one. I wish I could sleep, but my stupid ADHD kicks in, and well, basically it's one sheep, two sheep, cow, turtle, duck. Old MacDonald had a farm. Hey, Macarena. And it's kind of how they, one thing leads to another, and they get off on rabbit holes. So sleep hygiene can be really helpful, but things like medications like melatonin can be really helpful. But you want to get it from the major pharmacy companies, which are much more reliable. That's like Walgreens, Walmart, CVS, Rite Aid, stuff like that. Clonidine, trazodone, those are all, mirtazapine, doxepin, those are all non-habit forming things that can help with sleep, and that can be really helpful. And if they don't sleep well, they're not going to do too well with their focus. Coaching is another thing. Why coaching is needed, because medications don't fix everything, and not all patients respond as well. You might have a 90% response or an 80% response or less, but we want to get the best response to medication first. But if whatever you have left, then you really do want to do some other things. And as a parent or grandparent, you can do coaching. You just got to figure out how to, what things help. So it's not counseling, really. It's not going into psychological issues, but it's more like athletic coaching. And an example, like I do a lot of this when I see patients in the office, and they're having trouble with bringing their homework back. You know, a lot of students with ADHD do their homework, just never sees the teacher because they have so much difficulty getting it actually to school and getting it turned in. So I'll, you know, coach them to, you know, once you do it, you put it directly in your backpack or whatever, and then, and not only in your backpack because it can stay there for years, but you can put it in, you know, put it in a folder where you take everything out of that folder every single day, and they have to get into that habit. But you can coach them with things like that. You can coach them with things like, okay, if you are going to get stuck on social media, you can't turn it on until after you're finished with your homework. You can't turn it on at all. You know, you have to use a timer if you're going to do something like social media or look at YouTube. You set a timer. When it goes off, you stop immediately. You get in the habit of doing that. So you can, coaching works better for when they're older because they have a desire to do to achieve whatever it is you're trying to achieve. Younger kids, you have to kind of be their external control to some extent, but you know, you can still start coaching them. Set up structure, you can provide, you know, set up different goals for them. You can help to identify some of the things that they're having difficulty with and work on ways you can, the mechanics of it. How can you get around this? How can you make it work out better? And other behavioral interventions, again, brain function, it's a neurologic condition. Brain function will actually get a little bit better with certain things that you can do externally, but it's really, if the brain function is better, everything else will work much better. So CBT was found to be, that's cognitive behavioral therapy, was better for adults than for younger people, but it can be effective with adolescents. There's some evidence for that. One of the things that's kind of interesting, this was one I came across, but individuals for whom religious activity, spirituality, prayer, things like that was important, actually showed a difference in their brain in the function in the areas where ADHD affects it, so that it can actually be a big help too. So you're you know, meditating, praying, things like that, having a group experience, you know, going to church, going to small groups, whatever it is, that can be really helpful. Now the new drugs in development, I'm not going to spend any time with it, but just to say there's a whole bunch of them. They all have different mechanisms. A lot of them are the same medicines. Like we have Daytrana, that's methylphenidate in a patch. Now they're working on an Adderall patch, for instance. We have a timed release liquid of methylphenidate that's already out. They're working on a timed release liquid of Adderall. That is, and that I was skeptical at first, but it's an ion, a polystyrex ion. This doesn't mean anything to you, but polystyrex ion exchange system that's pretty ingenious. That's liquid, and it's in suspension or in solution, and it releases over time. I would have never thought they could do anything like that, but it does really work for the amount of time they say it's going to work. Usually, for most of them, and there's one like that that's being directed. You know, now this one, for instance, is actually different from the others, and so this one's probably not it's in just phase 2 clinical trials. So it's probably not going to be out, but in 3 or 4 years, unless it gets canned before it gets to come out. But there's some of these that are actually different and some things we've never seen before. That what we'll be looking at is whether they have very high effectiveness or not, though. You know.
What have you seen with the triple ones?
That particular one, it's.
I mean, there's a bunch of triple.
None of them are out at this point.
No, I'm not saying out.
Yeah. Oh, I see what you're saying. Yeah.
In clinical trials.
Right. In clinical trials, they're promising, but they're kind of. It's an interesting thing now. The industry, you know, investors and stuff are watching all this stuff too. Right. So now you have to pay, you know, $20,000 to get that information at first. So I have to go through the back door different ways. I have to look for it and find it in different ways that are not costly.
It's MCI.
They don't. Yeah, they're keeping it under wraps a lot of times, the details about it. But so far it's looking promising because they wouldn't be putting the money into it. But we don't know yet how good they're going to be.
And isn't there I mean, there's a much lower threshold for rare diseases where they have a smaller populations.
Yeah, this is a really big population, but the problem is, and anytime you have a big population, medication development's going to be easier, and it can actually end up being a little less expensive than if you have a very small population, because they spread the cost over that small population. It's really expensive. But what we see is with some of these is that we have so many different medications. Usually, it used to be the FDA would not allow things that were Me Too medications very much, but they've been allowing it lately. So we have a broad field of medications that are very similar, and
money to rechange it
the
so they can.
the very similar medications and stuff, you know, will make it so that each individual medication is not going to have a whole lot of patients using it necessarily, unless it really stands out, you know, to be very effective. So we'll see about that. I wish we could. Wish it was, you know, we had more. I wish they could come out a little faster so we could see which ones do stand out a lot. But I'm just giving you an idea of how many there are. There's a bunch of them. Okay, so in summary, the research, a lot of it's going on. Lots of things we can do to help ourselves, our kids, our grandkids. Some of it's, the medication works really well for most of them, if you adjust it appropriately. And that's where it's, you know, important to keep on working with it. And then they're threshold mediated, and it does extend into adult life. And then non-medical interventions can be really helpful, although the research has shown, you know, that they don't make that much difference in general. I think it makes more difference than research has shown. But in individuals, some individuals really do a lot better with that kind of, with the non-medical approaches. And most people need some modifications to whatever they're doing. Whether they do it themselves, some kids just do that automatically. They figure it out on their own. But some of them need things like coaching and other things, other modifications to make them make a level playing field so that they can do as well as their peers and not be disadvantaged by their ADHD. All right, that's it. Questions?